two cases. The first one is a 64-year-old man who presented from an outside hospital with aphasia and right facial droop. The CT scan showed a hyperdense mass that was concerning for a lesion. So here at the BI, he had a contrast study and MR, contrast CT and MR, which confirmed the presence of a peripherally enhancing mass. Differentials were a glioma or carcinoma. Went on to have a biopsy, which confirmed a glioblastoma. So prior to the diagnosis of the glioblastoma, they did a CT scan of the chest, abdomen, and pelvis, looking for a possible primary in case the brain lesion was metastasis. And this is what it showed. It showed a fairly well circumscribed mass in the left hemipelvis. It looked like it was arising from the prostate. We don't have a pre-contrast, but it sort of looks like it's enhancing, it's hyperattenuating. And we were a bit concerned, obviously, because this man is known to have malignancy. Does anyone have any possible differentials for this mass here? This setting?
So Gitanjali says leiomyosarcoma.
Okay.
I was saying some kind of mesenchymal or stump tumor of the seminal vesicle.
Okay, yes. Okay, so thank you. I will now go to our report. So, of course, we described the mass. We thought the appearances were atypical for prostatic adenocarcinoma, and the two main diagnoses we're thinking of were a stump tumor and a sarcoma. So he went on to have a biopsy, a CT-guided biopsy, and actually the histology has just shown BPH. So apparently exophytic BPH is exceedingly rare, but I could only find two previous case reports, but that's what it was, no evidence of malignancy at all. What they've said is that it's just an overgrowth from the transitional zone, a bit like what happens when it goes into the bladder, but now it's now growing outwards. There was one MRI, a set of MRI studies showing that it looked hypo-intense on the T1 weighted images and predominantly hyper-intense on the T2 weighted images. So non-specific, but not much to find in the literature about it. But yes, this is just showing that she can have a large exophytic BPH. But more interestingly, because I didn't know much about these other two tumors, so I looked into them a little bit, and I will just talk about them briefly. So prostatic sarcomas, they're rare tumors. They're less than 2% of all primary prostatic neoplasms. So the commonest prostatic sarcoma is a rhabdomyosarcoma, which is usually seen in kids and adolescents. And the commonest adult one is a leiomyosarcoma. It's they're usually well circumscribed masses that are homogeneously hypo-intense on T1 weighted images and heterogeneously hyper-intense on T2. They enhance avidly, and because they grow quite rapidly, there is usually a central area of necrosis. And I've got some images off the internet showing a large mass, which is similar to what we were looking at. So the only difference, of course, is that this mass now has central necrosis. So I think those were reasonable differentials that we gave in our report. And the other differential was the stump tumor, which is a rare proliferative lesion of the prostatic stroma. It's described as being heterogeneously predominantly low on T1 and T2, may arise from any prostatic zone. It has a wide range of biological behavior, so it could just cause compression of adjacent structures, or it could actually invade adjacent structures and metastasize. It's described as being indistinguishable from prostatic sarcomas, and it can actually mimic a BPH. Therefore, they've said any large BPH or unusual one, like the one we saw, should certainly be biopsied. And patients with this diagnosis usually undergo resection because of the potential for aggressive disease. So
Margaret, do you think in retrospect, an MRI would have helped?
We actually discussed that when the results came out. And to be honest, the attending I was with thought it might help, but I think it was rediscussed, and the urologists and some of the other radiologists were quite confident. And looking at the biopsy was quite clear, and regarding the number of samples that had been taken, was quite clear that the lesion had been adequately sampled. And yes, so I think they felt confident with the diagnosis. I've looked through the notes. They've put this to bed. They're not looking at it at all. Yeah, so they haven't done an MRI.
And there wasn't.
Can they?
Sorry, go on.
Oh, can they make a diagnosis of stump on core biopsy? Because I mean, we looked at this case before, right? Or a similar one, Arthi. And BPH is in the spectrum of stump.
Yeah, I just remember, Nellie, you showing a similar case where we were
I
like,
think it's a stump.
It's a stump tumor, and then we're like, it turned out to be or something like that. There was I guess maybe a spectrum.
Oh, are you saying that histologically they look the same as well?
Yeah. Oh, yeah.
Oh, there could be a spectrum, and maybe because you're saying the biopsy showed glandular and stromal tissue, so I guess.
Yes, it did. It did show that. It showed glandular and stromal overgrowth.
We looked at the path literature, remember? And stump is like, it can be misdiagnosed routinely as BPH.
All right. So from your point of view, this could still be that. A benign
yeah, totally.
Stump. Okay. All right. Yeah.
Take it back to the pathologist, man.
Yes. He has a glioblastoma, so I'm not sure what his life expectancy is. But
can you go back to the imaging?
Yeah, actually, the stump is not going to make.
Because it looks like it's like a seminal vesicle. It's not even like, you know, it just looks weird. I don't think this is a BPH nodule.
Yeah.
So
I'll certainly follow this up, and if anything changes, I'll bring it back to this meeting here.
You know, can I pitch in on? I've seen this scan. I mean, it was shown as an interesting case as well. Earlier, the seminal vesicle was displaced medially, Nelly. We don't quite see that image on this particular axial image that has been chosen. But if you scroll through the scan, the seminal vesicle was separate and it was pushed medially, and you could see that this thing arose from the prostate.
I see. Now I want to see the MR even more. Maybe we'll just get it for
no MR.
satiating our curiosity.
But I also think that, like she's saying, if they have glioblastoma, like this is not going to be pursued, and because stump, we don't even know, it's uncertain malignant potential. Right?
Oh yeah, totally. I mean, there's a bigger fish to fry.
Okay.
Cool.
All right.